Hi, everyone. Greetings, everyone. It's my pleasure to introduce our speaker, Dr. Trish Suplee. She's the Director of Professional Education and Research at Central Jersey Family Health Consortium. She's also an Associate Professor at Rutgers University in the School of Nursing in Camden. Her career has focused on improving maternal child health outcomes and translating evidence into clinical practice, especially during the postpartum period. Dr. Suplee's collaborative work has been a part of leading AWHONN's Empowering Women to Obtain Needed Care project, and that work led to the development of the post-birth educational tools that many of us know and have received national attention. She's been a part of developing multiple Alliance for Innovation in Maternal Health patient safety bundles. And Dr. Suplee was a member of the Health and Human Services Office of Minority Health Think Cultural Health team to advise the development of an e-learning program for physicians, nurses, and healthcare providers about culturally and linguistically appropriate services in maternal health care. And I'll pull up and put a link to that in the chat. She is chair of the New Jersey AWHONN and is a member of the New Jersey Maternal Mortality Review Team that analyzes cases, identifies gaps in care, and makes recommendations to decrease maternal mortality rates. It's so wonderful that you've made time to be with us to share some of your latest work so we can think together about how to apply that more into practices across North Carolina. Thank you.
Great, and thank you so much for having me. I'm well aware of your work down in the South and really are appreciative of everything you all are doing. So again, thank you for having me. Let me see how I can do this screen now. Let's see. Can you all see my slides?
Not yet.
Not yet. How about now?
Yeah, looks great. Thank you.
Okay, great. Thank you so much. So again, today I'm going to be talking about engaging with birthing families and their support systems about potential postpartum complications. And just for a disclosure, I am a consultant for AWHONN and also a member of the team that developed the postpartum AIMS bundle. So I do like to say that right up front. I'd like to start this presentation with just a little bit about my journey. And I think it's always important to share a journey as people look to mentors and leaders to kind of figure out how did they get to where they are. So I think it's important just to share a little bit. I really love this saying, and I love this saying not only for life, but also as a clinician. And again, I am a labor and delivery nurse. That's basically where my clinical expertise lies, having practiced as a staff nurse, nurse manager, clinical specialist, basically in primary tertiary care centers. And like many of you, I've witnessed the so-called low risk labeled birthing person become high risk, and I've witnessed the high risk labeled person really sail through labor and postpartum without difficulties. But we always have to remember that we cannot always predict who's going to have a complication and who isn't. So I always bring that to the forefront. And the practice environments I chose were mainly inner city hospitals where health disparities and social determinants of health were contributing factors to so many poor outcomes. So from practice, I entered academia, teaching at Penn, Drexel, and now at Rutgers. And I focus on how best to educate students, to challenge, to think critically when caring for maternal child health and clients and their families. And it's really important to not only teach how to care for the clients based on their diagnoses and interventions that we do, but it's really vital to thread how we provide compassionate, respectful care at the same time. And that's sometimes difficult to teach because sometimes I find that comes from within the person themselves and their own experiences, what they bring to the table. So to see the person first and their family and gain insight into their specific needs rather than just provide a cookie cutter approach. And don't get me wrong, I love protocols, I love algorithms, I love developing practice guidelines, I love living in that world. Especially when you see that they do lead to positive outcomes. But I want to stress in this presentation the contributions that staff can make to improve maternal outcomes in all practice environments by having a heightened awareness, ability to question and listen to our clients, and also for those who support them in their own journey. So objectives are here for you. I'm going to briefly go over some rates, leading causes, which I know you've probably heard before, but I like to introduce it because it kind of lends itself to why we did what we did. Examine the development and integration of A1's post-birth warning signs into discharge teaching, how to best initiate conversations when teaching clients, and also then summarize the multiple touch points we've been having, and to obviously recognize multiple resources that can be used when guiding some of the clinical care we do, but also how we educate. So the first thing I want to talk about is maternal mortality. Obviously, it's gained national recognition. We have reported lastly in 2020, 860 women died. Which is extremely problematic. But I do want to say that some of the reporting and the numbers do vary depending on who is reporting, how the data is gathered, and how data are interpreted. And this number, again, is from the National Vital Statistics System. Unfortunately, and extremely worrisome, is that Black females have 3 times the rate of deaths compared to their non-Hispanic white counterparts. And the rates are also increased for maternal age, especially for those over the age of 40. When we look at pregnancy-related mortality ratios, otherwise known as PRMR, you're going to see that this is the chart that was produced by the CDC from 2005 to 2018. They haven't produced an updated chart, but I did go ahead and add the 2019 and 2020 rates. And as you can see here, these are pregnancy related. And again, just for a definition, the death of a woman during pregnancy or within 1 year of the end of pregnancy from a pregnancy complication, a chain of events initiated by pregnancy, or the aggravation of an unrelated condition by the physiologic effects of pregnancy. That sounds very complicated when we look at a definition. However, it's important to define a pregnancy-related death compared to a pregnancy-associated. And a pregnancy-associated is the death of a woman during pregnancy or within 1 year of the end of the pregnancy from a cause that is not related to the pregnancy. So, for example, you may have a woman that dies in a car accident at 8 months postpartum. That is a pregnancy-associated death. However, it's not really related to her pregnancy. The other thing I want to touch on here is the term preventability. We've been hearing a lot about, oh, so many deaths could have been prevented. And preventability is a death that is considered preventable if the committee that reviews the cases determines that there was at least some chance of the death being averted by one or more reasonable changes to either the patient, the community, provider, facility, or system factors. And basically they're saying about 60% of maternal deaths could have been deemed preventable. But I like to caution people on the perception of what that means, though, because it doesn't mean that 60% of deaths maybe could not have happened if one thing was done. It's a matter of the committee looking at the case and saying, could this possibly have been prevented if this was done, or if this was done, or if this was done? So again, it's not a permanence. It doesn't mean that if that was done, that woman would have survived. It could have increased her chances of survival. So I just want to be very clear with that definition. When we look at causes of pregnancy deaths, you will see here, this is from 2014 to 2017 in the United States. We do see that cardiovascular, and again, you'll see in the pink highlighted here, cardiovascular conditions, cardiomyopathy, hypertensive disorders really are the main cause of death in the United States, followed by, again, infection, sepsis. We still have issues with medical non-cardiovascular conditions, which kind of is like a catch-all there. So that could be a woman who dies of potentially cancer, diabetes, conditions related to other organs in their body. So again, that's kind of like a catch-all there. I do want to say, though, that when you look at worldwide deaths, worldwide, the three leading causes are still hemorrhage, infection, and hypertensive disorders. So we have gotten better in some of our categories over time compared to the world, but unfortunately, our rates are still high for those countries that we are compared to. And then when we look at timing of the deaths, as you will see, primarily the majority of deaths do occur in the postpartum period, and that's this here in green, where 31% is in the antepartum, the 17% is delivery day. And again, I want to caution you, these are data from 2011 to 2015, reported in 2019. So depending on the article, depending on the resource or source you're getting, you may see over time that these have changed. I do want to say in New Jersey, our last public reported data is from 2016, and we had 70% of our deaths are occurring in the postpartum period. So we really have been focusing on that period when we look at, preventability, obviously, but also when we take the journey back of the woman. So if she died in the postpartum period, when was the last exchange she might have had with a provider? Could it have been that 6 to 8 week postpartum visit that we still kind of see being a standard? Versus, is this a person who never went back to the postpartum visit versus somebody who switched over to a medical home and had care, primary care, et cetera? Sometimes it's hard to follow these through or follow them back to see if we could have prevented that death. Now, on the other side, what you're seeing is a breakdown of postpartum deaths according to when they occurred in the postpartum period. So as you can see here, this was reported in 2019, looking at deaths between 2011 and 2015, and also from 13 states between 2013 and 2017. So what you see here is, if you're really looking for, well, what's really happening in that postpartum period and when it's happening, you can see, for example, on delivery day, hemorrhage, amniotic fluid embolism, cardiovascular conditions are really the top three. And they start to change over time. The first week postpartum, wow, we're back to hemorrhage still, which some people would say, wow, I thought that would only occur in the hospital. Hypertensive disorders and infection. And when I start talking about postpartum rehospitalizations and revisits to the emergency room, you will see that hypertensive disorders really do drive that first week. Day 7 to 42 takes us to about the postpartum visit, infection, cardiovascular conditions, and cerebral vascular accidents or strokes. And then we switch to a very extensive and long period of time from about, the 7 to 8 week period all the way out, extending to a year. Cardiomyopathy, non-cardiovascular conditions, and then cardiovascular conditions. Can you still hear me?
Yes.
Oh, okay. I'm sorry, my earbud fell out. Yeah, so that's really important. The other thing is, when we look at the recommendation that ACOG has recommended, where there's a touch point about 3 weeks postpartum, that really hasn't taken off nationally. Some places are doing that, whether it's a phone call, whether it's a visit, whether it's a telehealth visit, but it hasn't taken off nationally. In New Jersey here, we are actually looking at a 3-week Family Connects visit. We started a Family Connects program in December, so we're very early into the program, doing it in one of our counties. I'm the nursing supervisor for that. So again, we are doing that touch base to see if we're finding anything. Reported yesterday to us, it was exciting to hear that 100% of the women that have been interviewed, because we've been mainly doing it virtual because of COVID, we're just getting back into the homes, 100% have gone back for their postpartum visit. So that actually was something good to report from very, very early with our work. So let me touch on readmissions here for a little bit, because sometimes they get lost in the shuffle. So again, we calculate out mortality rates, but what isn't clear is how postpartum morbidity rates are captured. So again, if we look at data from some literature on hospital readmissions, we actually find some different things. Now, you're going to say, well, 1 to 2.5%, that's kind of low for readmissions, but let me read you off some of these numbers from some of the literature. So in 2016, Clapp and colleagues, he reviewed cases of postpartum readmissions in the first 6 weeks of those who delivered in California, Florida, and New York. So it was an 8-year span of time. They found a 2.16% of all deliveries were readmitted, and it accounted for roughly 115,000 women. The most indicated reason for readmission was infection, followed by hypertension issues, and then psychiatric illnesses. And most of those readmissions occurred on average 7 days after delivery. So again, a week. Nassab and colleagues in 2018 looked at readmission rates as a quality indicator. This was done only at one hospital where readmissions were reviewed over a 17-month period of time. They had a 1.55% readmission rate, with hypertensive disorders being responsible for 42% of those readmissions, and then wound complications for 18%. Another study in 2018 was by Kim and colleagues. They did a retrospective review of 644 women from 2013 to 2016 with a readmission within 6 weeks of delivery. Their rate, again, 1.2 to 2% of all deliveries. 80% of cases were related to OB reasons, and 49% hypertension, 14% sepsis. The mean day for readmission in their study was 7.5 days for OB complications. So again, pretty problematic. And then the last one I just want to report on is in 2020, Wen and colleagues. They looked at fragmentation of care, and I think this is really important. They used the national database of readmissions between 2010 and 2014. So again, this is old data, but again, they're looking at a retrospective national set. So again, it was reported in 2020. They found that 15% of readmissions occurred in hospitals that were not the original birthing hospital. These researchers found that women admitted were more at risk for severe maternal morbidity and increased length of stay within, again, 60 days of delivery. 141,000 readmits were noted, and 21,000 were readmitted to a different hospital than when they gave birth. So again, I want to bring this up because, so often we focus on our birthing hospitals for what we have to do, what we have to provide. And again, I think it's important that we start thinking a little more broadly about those hospitals that may not have, birthing centers or that they deliver, but birthing people still show up in their emergency rooms. So what are we going to do about all this? This is where, the project I want to talk about today kind of fits in. You probably all are aware about A1's post-birth warning signs. We started our research and quality improvement projects in 2015. I can't imagine that it's been 7 years. It was supported by a grant from Merck for Mothers given to A1, and I was PI on the project with Dr. Deborah Bingham. Ann Santodonato and Lisa Kleppel were both part of our team at the time. And we designed a two-phase study where we were concerned about what was really going on in hospitals with discharge teaching. And when we took a deeper dive into the literature, we really weren't getting the answers we wanted. So, therefore we found the gap that we always kind of strive to say, find the gap and go for it. So what we basically did was we wanted to know what is being taught, how is it being taught, what is the best practice for teaching, and it was kind of a blur. So what we did was we started a phase 1 and phase 2 research and QI project, with the first phase being an exploratory qualitative study. And basically we looked at 6 focus groups that I facilitated. They each had between 5 and 11 nurses in each group, and there were 3 hospitals from New Jersey and 3 hospitals from Georgia. And again, we chose these hospitals because we really wanted a population that was very diverse, and we were able to do that. The other thing is when we had nurses, when we were asking the nurses, we really wanted to get at the bedside because we wanted to hear their voices of what they were doing, what they were speaking of, what they were teaching, how are they doing it? So again, that's why we chose to do the focus group aspect of this research. We ended up with 52 nurses, 77% were older than age 40, 77% were Caucasian, and 58% had greater than 10 years of postpartum experience. So this was a group that really was doing, postpartum nursing for a long time. So again, it was kind of interesting because when we started getting our results, we were a little, I'm not going to say surprised, but it gave us the information that we needed to say that this really needed some more attention. We looked at written materials, their audiovisual materials. We basically then interviewed them in groups. And I just want to share with you some of the comments because I think comments are very powerful sometimes. So one of the things we would bring up a topic and we would just say to them, tell us what you tell patients about this. So for example, like obstetric hemorrhage and bleeding after they go home. And majority of them talked very clearly about saturating a pad. What does it mean when you do that? What should you do for that, etc. When it came to clots, many described the size of a clot that should be concerning to a woman, but they were kind of all over, larger than an egg, larger than a golf ball, bigger than your fist. One saying a plum, but not a Costco plum. Obviously Costco has big plums, I guess. An apple, a pear, the size of a quarter or a cluster. What should you do if you experience clots? Some said go to the ER right away. Some said call your provider. Some said just keep an eye on it. So not only were we getting different things for how to describe these to a woman so she can better assess, but we were also getting very different answers for what to do with the information if they did find it. Another thing was when we asked the nurses to describe what they say about venous thromboembolism or DVTs. We will wait until somebody is symptomatic. That's what one nurse said. I basically don't teach about it. It doesn't say it on the form. To be perfectly honest, if it doesn't trigger me, I'm not going to do it. We're doing postpartum pulse checks. So again, the correlation between a postpartum pulse check and a DVT there. I address DVT more often with Spanish people. They tend to want to lay around for certain amounts of time. That's just their belief. So again, we got into like people having beliefs about different populations without really talking about what that belief might mean. Versus is it cultural versus is it, again, it was really surprising some of the phrases we heard. And again, some of them were troubling. On the other hand, some of the nurses nailed it. They nailed, the responses, what they were saying, when they were saying it, what to do with that information. So that was like our first aha moment with, okay, we need to do something about this. We then developed this tool. Now, I want to talk about the tool development because it wasn't something that occurred overnight by any means. When you're developing teaching tools, a lot goes into it. We needed to have a script. What we found was a lot of nurses were concerned that they didn't want to scare people. They didn't think that they should talk about that they should die or they could die. They didn't think they wanted to kind of give them too much information. So we did script a message, which is right on top. Most women who give birth recover without a problem, but any woman can have a complication, and learning to recognize these post-birth warning signs and knowing what to do can save your life. Now, that was one of the phrases we initially started with because we heard from nurses, I don't even know how to open up the conversation. So that was one of the phrases we did come up with. What we also wanted to do was what to assess for and when to call 911 versus a provider. So you can see here we spelled out post-birth, which that in of itself was no easy task because it took us a while to kind of put that together. But also we were thinking about the red, yellow, green of a traffic light. Red, you want to do something right away. You want to stop and really do something. Yellow, you've got to slow down, but we want you to do something. And then we also talked about trusting their instincts. We always instruct those who deliver if they didn't feel right to call someone, but that's so vague. And people find that so vague, but sometimes your instincts do kick in. So we wanted to stress that we would rather hear from you versus you sitting at home thinking, I don't know if I should call, maybe I should call, maybe it's not a problem, I don't really want to bother anybody. We really started talking to people about, we want to hear your voice. We want to hear from you. No matter what, we would rather be proactive. We gave them a script. I gave birth on which date, and this is what I'm having. And we provided a little script there for them because sometimes patients don't know how to open up the conversation. So we wanted to give them that. And also the opportunity to write in the provider name, the phone number, right on this form. We did include an explanation on the bottom, you can see there, of what it might mean. We felt it was important for the patients to understand what these might mean, but also when they heard these words being presented to them in the hospital, they would kind of have an idea. However, as you can imagine, putting that there increased the readability of this tool. So we focused on how the boxed information really was fine with readability. And if they wanted to read more and get more in depth, they could. So that's kind of how we went with the readability piece. When educating, there's a teaching tool that also goes along with this. So this was the patient teaching tool. We also designed a nursing teaching tool, and more so that they could teach off of that tool, or it would provide them with a lot of background so they too understood what this was all about. The tool obviously is A1's tool. Again, it was funded by Merck, and it's been designed to utilize and practice. Any person who wants to use it could notify A1. You can use it for free. They have it translated into 5 different languages now. They have magnets that hospitals sometimes will hand out the magnet. I often encourage nurses to say to the client, take a picture of it while I'm here, so they have it right on their phone as well, so they can refer back to it. The other thing is we really wanted the nurses to educate in front of somebody else, a support person, whether it was the significant other, a family member, so they too heard the information. And I can't stress the importance of telling birthing people, we want to hear from you. Do not let anyone make you feel that what you have to share is not important. And this is where it is vital that we train providers at all levels to stop and listen. Then ask more questions. Say, let me repeat what I hear you saying, assess, and then take the next steps. And even if it turns out that all you will be giving is reassurance, that in and of itself is vital on how the person will perceive the care they received. So I often say, I want to thank you for bringing this to my attention. After listening to what you told me and investigating, I believe what I see is, or what you're feeling is. I then review the post-birth warning signs again with them, and then end with, please do not hesitate to contact us again. So I think, again, you just want to keep circling back, but really teaching providers how to listen. And, you know, after this phase, what happened was we were sitting around a table and we were like, you know what, this information is from 6 hospitals. What's the national representation looking like? So what we ended up doing was a national study. Basically, you will see this was a poster presentation that we did, myself and Dr. Bingham, and we really looked at designing a questionnaire that we really wanted to capture what we were finding. So we designed a very short questionnaire. It was distributed around the country. 372 postpartum nurses completed it. And what you will see here is that most were BSN prepared, about 50%. And again, we did also find that majority of the nurses here were over the age of 50, and they had extensive, greater than 10 years of nursing experience. So this population was really a population of nurses who had been doing this for a while. So we asked about the likelihood of discussing potential complications with birthing people about certain topics. So again, I know you can read this here as well as I, so I'm not going to go through them all, but I'm just going to point out one. So up in the middle, you're going to see there's a chart there for that lists disorders. And let's just look at hemorrhage. So for hemorrhage, what you're going to find is 77% were very likely, and 5% somewhat likely, and 16% likely to actually talk about hemorrhage. Now, in most studies, you would think that's pretty good. Majority are teaching what they need to be teaching. But why weren't all nurses responding that they would very likely teach it? You know, so think about that. Like, you know, only 77% said they were very likely to teach the woman about potential for hemorrhage. Was it based on their opinion, on the likelihood of that particular patient? Or shouldn't all people hear about that message? So you can see from the rest of them what we found. The tricky one that, you know, if I had to do the study again, and again, we always learn from studies we do, is the how we phrased cardiac condition. It should have been cardiac condition instead of cardiac event, because I think maybe nurses perceive that is that they would have a heart attack. So once again, if I was to do the study again, I would have put cardiac condition in there. We asked then about how confident they felt teaching about certain topics. So again, same topics, but how confident are you about teaching? You know, are you very confident to, you know, not at all confident? And you can see there, most felt very confident with teaching about hemorrhage, for example, but look at the results for like DVT, pulmonary embolus, cardiac event. You know, it gets less likely that they're confident on those specific topics. And in general, over 46% of the nurses we surveyed were not aware of rising rates of maternal mortality. So again, just a question, are they rising? Are they staying the same, or are they decreasing? A very simple question. 46% were not aware that rates were rising. And finally, I just want to touch on the chart on the bottom right. This again, we were really interested here in what's the likelihood of discussing signs and symptoms now. So we laid out all the signs and symptoms that we really were hoping that they would talk about. And the goal obviously would be that this whole block was green. And we didn't get it. So we know we still had work to do. So you could see where they were very likely to teach about, bleeding, potentially clots, infection, but look at those bottom ones. Again, it got down to only if relevant was a topic, and that became problematic. Think about that. So only if relevant was because the client already had a condition of relevance versus did I decide by potentially looking at that client whether or not I was going to teach about that because I might or may not think they would develop that. So again, we had to also get into looking at perception. And going back to those focus groups, we did have some comments from some of the nurses on, well, I would teach them that if they were a clinic patient, but I wouldn't teach them that if they were a private patient. And when, again, we have work to do. All right, so I want to switch gears a little bit here. We're going to be talking about the provider's role in improving maternal outcomes. And the first thing I always talk about is starting with you, having a self-awareness of your beliefs. First of all, equity beliefs become important, obviously, with the health disparities that we have in maternal infant care. We are exploring them more. You're hearing more about implicit bias education and racism education and systemic racism education. But the bottom line is we still have to become more self-aware of all those things. How does society influence us? How does our upbringing influence us? How does the population that we care for kind of influence our decisions on a daily basis when we practice? And then getting into competencies. When was the last time some of this education was brought up? We talked about how some of these populations were nurses who have been out in the field for a long time. Well, maybe they really haven't had as much education on changing topics, but also how those topics have evolved looking at best practice. What is the provider's responsibility in maternal outcomes? Well, how much do we own? That's important to recognize. The perception, what is our perception of this problem? So again, when we asked nurses and, they really didn't think it was that big of a problem, we have to then say to ourselves, well, if our providers don't understand the perception of the problem, how is the public truly going to understand the perception? So perception is important. And then finally, integration. How do we integrate what we know, evidence-based practice, into our daily interaction with our clients? The next one is reflection. How did the healthcare provider in this situation respond? How would I have responded differently? What would I say to this patient? What would I do differently? How will the patient remember this experience? And I think sometimes it's so vital that we take into consideration what the client really hears when we're speaking, when we're talking, when we're educating, because as we all know, we learn in the moment, but at the same time, the people that we are sometimes educating are hearing so many things, especially before they leave the hospital, that it all gets blurry. We don't really know when we look at how much they retain, what can we do better with retaining? But what we do know is if deaths are really high and readmission rates are high in the first 2 weeks, we have to give them that information before they leave the hospital or birthing center. And then we have to say to ourselves, what's the best way to do it? And how will I know if they really listened? And I'll be going over that in a minute. So when we're engaging, we want to assess the individual's needs. We want to teach during every exchange. We want to provide consistent messages, and that was part of the A1 Save Your Life handout. We want to stop, look, and listen. And you've heard that phrase before, obviously through ACOG, but also through the Tara Hansen Foundation, which I'm going to touch on. And I want people to reassess when their role ends. And what I mean by that is, take, for example, the nurse who might be discharging that patient. Was the referral made to X organization, or was the referral made to a community organization that's going to continue? Was the phone call made to give that patient the follow-up visit? Does the person know when the follow-up visit is or when to call? Where does my role end there and somebody else's role takes over? So I think we really have to establish better communication, not only between providers, but between services, so people don't fall through the cracks. Just to touch on the teach back method, I know you've probably heard about it. Basically, we want to assess readiness to learn and learning style. But boy, they're only in the hospital for a few days. How are we supposed to accomplish all this? So again, it takes training, it takes understanding. And you never want to assume about a patient's previous knowledge. And, just to share a funny story with you, when I delivered at, a hospital that I was familiar with, and they were kind of familiar with me. But again, some assumptions were made. Well, God, she does this for a living. She doesn't need to know anything. But you know what? I've never taken care of a baby. I never breastfed before. Just because I teach it, it didn't mean that I knew how or what, or, I still had so many questions. And it's something that it was an eye opener for me, because I had to realize too, as a nurse, you can never take anybody for granted for their knowledge. Even if it's a physician, if it's a nurse, if it's anybody, you can't. You still have to assess where they're coming from. What you also want to do is address their concerns first. And I also say this even to students, because what I find is if someone has a question, they are going to continue to, in their head, think about that question. I don't want to forget to ask them about this question. And therefore, they're so worried about forgetting the question that they're not listening to what you say. And this goes for students as well. I usually start with, before I ask you guys any questions, what questions do you have for me? You can start again. I want to make sure you're comfortable with what to look for when you get home that may be concerning to your health. I know I just taught you a lot of information. Let's review each one so I can make sure I taught you correctly. Again, I'm taking the ownership. I want to make sure I taught you correctly. After reviewing all of these signs of potential warning signs, can you tell me when you would call your doctor or midwife? Again, just kind of having that phraseology that helps with the teaching, and you also get a better idea if they truly understood. All right, we're going to switch to touch points now. There are so many touch points that my circle for touch points have grown over time. And when we talk about education, we tend to focus on discharge instructions. That's where we started, postpartum providers. However, there are so many providers and touch points within our own community. I'm just going to talk about in New Jersey. We started with postpartum nurses, but then we began the process of dissemination. And one of the first things was Maternal Health Awareness Day, which was proclaimed for January 23rd. In New Jersey, it became a proclamation in 2018. However, the maternal health awareness really started with Tara Hansen Foundation. And Tara Hansen was a teacher who passed away 6 days after she delivered from an infection from a 3rd-degree tear. And again, the tear was repaired. She kept saying she didn't feel well, but she was healthy, she was fit, she was uncomplicated. Basically, her words fell on deaf ears. And she was told, it's kind of pregnancy, normal stuff you're feeling. Go home, enjoy your baby. And unfortunately, she passed away 6 days after she gave birth. And in 2012, a year later, her husband founded the Tara Hansen Foundation in honor of her, focusing on education and raising awareness for maternal safety and improving maternal focused motherhood initiative. And And from there, we then went to having a day every year, January 23rd, and now it's a national day, which we're thrilled at. From there, we moved on to community health workers and home visiting programs. You know, those touch points of where this could be brought up again. We then went to pediatric offices. The New Jersey Academy of American Pediatrics joined in with education. We went to federally qualified health centers, prenatal education, because we were kind of like, well, we teach them about breastfeeding prenatally. We teach them about what to look for postpartum. Why aren't we doing postpartum warning signs prenatally? We went to health fairs. We go to anything in the community that we can provide this information. And the other thing is, I started real early with nursing student education because I thought, again, it's the next generation of providers that we have to bring up to speed. And believe it or not, our next project is focusing on non-birthing hospitals, is where we're going to focus next. So there are so many good resources out there. And I know your fourth trimester organization has some really wonderful resources. And these are just some national resources I just want to bring up as a reminder. You're probably all familiar with the AIMS bundles, obviously. We have a primary bundle for postpartum discharge, but we also have 2 supporting bundles. And I know Dr. Stude was on those committees with me, and it was great to work with her. That's where I first met her. And I know she's involved in your organization. The other thing are professional organizations, you know, A1 resources to ACOG, but also getting into midwifery organizations, pediatrics, nurse practitioners, et cetera. And also the Institute for Perinatal Quality Improvement, another space where they're looking to improve not only care related to health disparities, but also just trying to get organizations up to speed on quality improvement for maternal safety. The CDC Hear Her campaign obviously took off. Again, centering the patients and centering their voice, where the lived experience is expertise. Storytelling is important. And then finally, I wanted to talk about what we do in New Jersey. We have 3 perinatal collaboratives. We've divided the state into the North, Central, and South. And basically, all of these collaboratives focus on advocacy, education, and service to the community, but also maternal child health providers are educated throughout the state. So again, we are responsible for that type of education as well. And finally, here are my some of the references I've used for this presentation. And a saying, again, I started with a saying and I want to end one, is that, we are accountable, but more so, we're also accountable for what we don't do. And knowledge is very powerful. And if we have the knowledge, it's really important that we share this knowledge, not only for providers, but also for the clients and their families. So I'm going to end on that note. I honestly don't know how much time I took. I'm sorry if I took too much time. Let me check my time. Oh, I did. I took a lot of time. I'm so sorry. But I'd be happy to answer any questions.
I so appreciate your time. This was really powerful and so important. I appreciate you going over it so thoroughly.
Thank you again, Dr. Suplee, for the tools for action, and I think so helpful the scripts, right, for really implementing in practice. And I wondered if any of the attendees had additional words that work for, conversations and connection around this, because I think that that's what we need very much, like how to do this in the context of so much time constraints and so much, going on with assessments maybe at the same time, and with background noise and other, context matters. And I wonder, Dr. Suplee, if you have, thoughts about the ideal timing of health warning sign information.
You know what? We really talked about that. We even captured in one of the studies how much time people were spending on this right before discharge, with the majority of nurses saying 5 to 10 minutes. Now, then some, about 28% was 1 to 2 minutes. And I'm thinking 1 to 2 minutes of all this education. You know what? I don't think we'll ever be able to say this is the appropriate amount of time. I think the timing is more based on repetitiveness of them hearing it more than one time. Prenatally, 36 weeks, before they get started, before they get discharged. Again, a touch point, maybe 3 weeks, if that can be possible. During the postpartum visit, it's still time to teach about those, because even though majority of deaths do occur before that 6-week visit, many deaths continue after that 6 to 8 week visit. So again, the importance of getting people into medical homes, getting primary care, interconception care. I mean, there's all touch points. So I would probably say it's important for them to hear it more than once, rather than just do it here. But I honestly think that it's the multiple times of hearing that needs to take place. And the pediatric office, I can't stress that enough. People do take their children and the infants to see the pediatrician or the nurse practitioner. It's another touch point. It's within the first 1, 2, 3 weeks. Perfect time. So again, have the posters up, even if they're in the waiting room and they can read the poster and they can go, no, that's not me. Great. But what if the person's sitting there and says, you know what, I am kind of short of breath, but it's probably normal, right? Well, no, shortness of breath isn't normal. So again, multiple touch points.
Agreed. Well, this was wonderful. Thank you again. And I love this. You've got me thinking, and I don't have a response crafted about that we're accountable for not only what we do, but we do not do. And that's, and that means with, who we are serving and who we're not. And your work, it's so exciting that it's been translated and open access, which is so critical for this. So thank you.
Oh, you're welcome. You're welcome. And I'm so happy just to kind of, again, just to have people hear and to exchange ideas and how best to do things. And it's really important that we just keep moving. Nothing's stagnant. Some people may look at the tool and say, this should have been on it. Well, that should have been on it. And you know what? A tool's a tool. You have to still take the tool for what it's worth. But if somebody has another condition, if somebody has another risk factor, you have to address that first. Like, that's going to be really important. So it can't just be, just use this now. This isn't enough. You still have to do that assessment. And the community work, are you discharging a person? And we talk about the word home. In one study I did, many women were being discharged to shelters. They never shared that with anybody because they were either too embarrassed or they were fearful that the baby wouldn't be able to go home with them. So again, we talk about when you get discharged home, is there another phrase for that? Instead, I usually say, tell me where you're going when you leave here today. And some of them, well, you know what? I'm going to my sister's. Okay, let's talk about your sisters. Again, it's opening up that dialogue without making presumptions, with not making assumptions that, they have a crib, they have to have a car seat, they have to have this, they have to have that. So many of our clients don't. They don't have it. And again, if we can get them those services, if we can get them connected with services that provide diapers, even diapers, sometimes they're not going to ask, but we need to ask.
That's a wonderful segue to our next community of practice will be, it will include Dr. Kelly Messingale from the North Carolina Diaper Bank. So thank you again. I'll pass it to Suzanne to close this out. So it's so wonderful to be in community.
All right, well, thank you everyone for joining. I put the evaluation link for this community of practice in the chat. If you would please click on that and submit, that's really helpful for our reporting purposes. Our next community of practice is, let me make sure I have it right, let me just make sure I have it right. I don't want to, May 26th at 12 p.m. Eastern. Registration is already open on newmomhealth.com. The topic is North Carolina Postpartum Care Innovative Clinical Practices, and we'll hear from, as Kristen mentioned, the Diaper Bank and Cone Health. So thank you so much, Dr. Suplee. Thank you everyone for joining. Take care.
Take care, everyone.
Bye, everyone.